7 years ago, the federal government put in place a new framework for health coverage with the Affordable Care Act. With Congress and President Trump working on repeal and replacement, researchers at the Pioneer Institute are once again favoring a policy that can be more closely tailored state by state. To explain how that might work for Massachusetts is the Institute's fellow in healthcare, Josh Archambault. Thank you very much for being with us, Josh.
Thanks, Chris.
First of all, the model that you're talking about, this is something really based on the work of a couple of authors at the American Enterprise Institute.
Correct.
It's called competitive federalism. What does that mean?
Well, it really means that we need to acknowledge that New Hampshire's not New Mexico and Massachusetts is not like many other states. So when we set up a federal framework for how we do healthcare, we have to respect those differences. And we want to see competition between states. Who can do it best? Who can drive premiums down? Who can deliver the highest quality care? And unless we allow that flexibility at the federal level, we can't see those results at the state level.
Well, you know, one of the things that these authors take issue with is a key part of the Affordable Care Act, and that is the expansion of Medicaid, essentially to cover more poor people or even working poor people, and they say that causes dysfunction. What does that mean exactly?
Well, there's a couple different reasons for this. The Medicaid expansion put a population on this program, which traditionally has been a safety net program for kids, disabled individuals, or pregnant women, and gave it largely to able-bodied adults. And so these are folks that we don't give other welfare benefits to. The other catch here is that new population came with extra federal dollars. So if you're a state budget writer and you need to balance your budget, which every state does, they end up prioritizing this expansion population over the traditional, truly needy population. That's the dysfunction that Obamacare kind of baked into. A lot of unintended consequences as a result of that, and that's why they're advocating changing the way that you structure the program or even who you cover.
Well, what about what that means either for the quality of care or the cost effectiveness of care? What do we know?
Well, healthcare is complicated, as you know, and all of these things are connected, although they may not always be obvious. So if you take the Medicaid program in particular, one of the concerns nationally, but also here in Massachusetts, has been access. So as you put more people onto a program that historically has not paid very well to providers, you get two things. You get one, more providers unwilling to take them, which hurts access. So we already have long wait times here in Massachusetts, even for those on private coverage. But when the public insurance, Medicaid, doesn't pay very well, it means that those folks, the truly needy in particular, find it even more difficult to find a doctor that will actually see them.
Well, what would be a good idea for replacing that Medicaid safety net for this population?
Sure. So I think Massachusetts has a couple of different things to say to this. The first one is we didn't have them on Medicaid previously under Romney Care. We had them in an exchange. I'm not saying you need to even keep those exchanges. I think ultimately what we need to do in this country is we need to move to a case where you don't lose your insurance if you lose your job. Or we make sure that if you need to purchase insurance, you're self-employed, you can actually afford it. So there's a lot of things that are maybe not that quite sexy, like insurance regulations, that actually matter to this. And one of the things that I think is so important and where this competitive federalism comes from is a number of states were doing some really great things before the Affordable Care Act. Maine, for example, they found a way to drop premiums for everybody and still help those with pre-existing conditions. It's kind of called something like an invisible high-risk pool. Very different from what Massachusetts has ever done. Much more targeted. Those are the sorts of things we want to see emerge and allow states to kind of copycat each other so that we can make healthcare much more affordable and ultimately have people that have access.
What about high-risk pools? I know this is not something that you find in every state right now, but I've read that some of these do not work out so well, they're not that cheap, or the coverage isn't that great. How do you get a good high-risk pool that's still affordable? Sure.
So just for viewers who aren't familiar, high-risk pools basically say we're going to take the sick people, we're going to move them off, and then we're going to subsidize them so that everybody else, their insurance can be a little bit cheaper. There's a lot of different ways to do this, and you're absolutely right. Some high-risk pools in the past have worked and some haven't. One of the biggest flaws has been they haven't been properly funded in many states in the past. What I think is important is that states get to do this a couple different ways. And ultimately, and where I come down on this, is you want to make sure that insurance companies don't have an incentive to avoid the sickest patients, that you help insurance companies when they end up insuring somebody who's really, really sick, who has a pre-existing condition. But you want to avoid the situation which Massachusetts has had, and unfortunately the Affordable Care Act adopted, which is regulations that have the insurance company price everybody as if they're sick. You want to get away from that. You want to move to a system where The insurance companies can price everybody as if they're healthy and yet help insurance companies when they end up with somebody who has a pre-existing condition.
This is BNN News. We're talking with Josh Archambault from the Pioneer Institute. Josh, what about the challenge that even people in Washington are struggling with right now? And that is, how do you get young and healthy people to buy insurance if you're not requiring it?
Well, I think that a couple things that we've learned is that the individual mandate and the Affordable Care Act did not work as intended. Those younger individuals didn't show up. So I think we have to step back and say, what is our priority here in healthcare? It's first, make it affordable enough so young individuals actually can afford it. It seems pretty logical, but it's not really where we are right now in the insurance market. The second thing is we have to realize that access is probably more of a priority than it is coverage. And I think, unfortunately, both nationally and here in Massachusetts, we have lost sight of the eventual goal. We want people to be able to get health care, not just have an insurance card. And so if we're able to acknowledge that difference and that distinction, then we should make decisions to make sure that people get access. Whether it's access to primary care or others, do they actually need to have an insurance card in all circumstances? Because many are going to choose not to do that.
Because one of the other possible ideas that could be followed, and this is, I guess, a political third rail, is we go away from tax-free health insurance benefits for people who are in plans sponsored by their employers. What would you be able to do to make that work?
Well, you're absolutely right. There's a political dynamic here, and there are kind of two issues here. You can't get to single payer, and you can't get to ending employer-based insurance because there simply aren't the votes in Washington, D.C. And so I think going forward, you have to say is, how do you make the best of a not great situation? A lot of the dysfunction we have in healthcare is related to this tax preference. So I think the way that it's being discussed, both on the Affordable Care Act and in some of the Republican repeal and replace conversations, is you just try to cap it. You put a containment on it so that individuals don't put all of their compensation into health insurance, that there is some sort of upper limit. And so as a result, individuals don't, they don't want to hide their compensation there. They actually have some sort of cap on it. At least it limits some of the dysfunction, but it certainly doesn't solve the problem.
What do you think about the willingness of employers to keep providing that kind of coverage? I mean, the Congressional Budget Office was saying that even with the Trump-Ryan plan, that could be eroding.
I think it probably depends on what kind of industry you're in. I think, by and large, in particular here in Massachusetts, there is a commitment to coverage, but it also reflects some of the industries that we have here. That they pay high salaries, they also pay generous benefits. They can afford to do so. In many other parts of this country, that's not a reality. So the question becomes, can we make sure that healthcare, the underlying healthcare costs, are affordable so that the health insurance is affordable enough? I think then you'll see most employers want to offer it. And for those situations where it's not, how do we enable those individuals who they work part-time, they work at manufacturing or at a restaurant, how do you allow them access to some sort of health care that's not tied to their employer? That's the real rub here. That's the debate we're seeing play out in Washington. And really, until we crack that nut, and maybe we have to tackle some of that at the state level, I think you're going to run into this problem. It's really, but again, just want to really focus, it's the underlying cost of healthcare that is making this whole debate about coverage so much more difficult.
And of course, in Massachusetts, especially here in Boston, some great healthcare, and sometimes it seems to be vastly overpriced for different reasons. So what do you do about that?
Well, you're absolutely right. I mean, we're talking that you could walk a couple blocks and get the same procedure, the same MRI, the same drug, the same treatment, sometimes 300% different in price, with no difference in quality. So I think one of the things that the way I think about this is until you gauge the individual patient, until you reward them, and there are programs out there that exist in other states where they say, look, you have option A and option B, drastically different prices. If you go to the lower cost, same quality provider, then we're actually going to pay you to do so. Those are the sorts of carrots that we should probably see a lot more of in healthcare to help address some of these cost issues.
Of course, one of the other factors here is that reimbursement systems, especially if it's a large system, they can distort the kind of healthcare that other people are getting. Medicare, as these authors point out, it does so much to shape the the structuring of care, that I guess it just distorts things when it's care for other people.
Yeah, you're absolutely right. I mean, Medicaid and Medicare have led to a lot of the dysfunction in the private marketplace, and not everybody connects those dots, this cost shifting that you're referring to. Again, I think the first step to address some of this is just to say, as individuals, as individual patients, for the 9,000 or so procedures that are plannable, non-emergency, and I'm sure there's even more, but we know of at least 9,000 that some transparency vendors say easily shoppable. So how do we change the culture so that individual patients are willing to drive an extra 10 minutes or walk down the block or go to a standalone clinic to save tens of thousands of dollars? And until we give patients those tools, unfortunately, I don't think we're going to get our hands around this. And it requires a culture change. And I hope Massachusetts can lead here again to say, we need to try something different. And it's about transparency, but it's about giving rewards to patients to be able to do the right thing.
What is it about this market, some of the advantages you see that make things better for us here in Massachusetts?
Well, like you said, we have some great healthcare institutions here in the state. It's local, especially for those that live in the eastern part of the state, in Boston in particular. We really have great resources. The problem is that we're not able to kind of pull back the curtain to make those decisions about where we get our care, or even to make them based on quality. Price is not a good indicator in healthcare of quality, unfortunately. And so until we come to a situation where an individual doctor or even institution can come to you and say, patient Chris, we want you to come to us because our readmission rate is lower, that our infection rate is lower, our outcomes are better, I fear that we have missed the mark in healthcare. And until we get the incentives right, where we actually have to be convinced to show up and to get care at that facility and to pay more, I don't think we're going to be able to drive down costs. And I'm hoping that some of the tools coming onto the marketplace these days will eventually get us there, but we're not quite there yet.
Well, one thing that even the Republicans in Congress are not quite at this point is getting to a piece of legislation that allows insurance to be bought across state lines. Now, I gather it's not easy for a new insurer to come in and set up a network and really be competitive. So is that really worth exploring?
Well, this has certainly been a talking point for quite a while for the Republicans. I think there are 3 states at least now that allow for a cross-state purchase of insurance, and there has not been a lot of activity in those 3 states. I think it's something to be explored as one of many, many options. I actually would prefer and would advocate to say there's another way. There's healthcare across state lines or even across town where an individual, if they find a deal out of their insurance network that's below the average price, for example, then they should be able to go.
That could be going a long way, though.
Sure, but it could also be going across the street. And so what I think what the Republicans and others who have said buying insurance across state lines is really getting at is price. And so if we allow consumers to be able to take advantage, to see the price differences within their insurer network, but also outside, because like you said, insurance networks are usually geographically based. But why shouldn't I be able to go to Manchester, New Hampshire, if there is an exceptional provider, even though they're not in my network currently, but if they're a good deal providing high quality care, then I should be able to go, and guess what? We're going to save money for the system as well.
Thank you very much for being with us.
Thanks.
Josh Archambault from the Pioneer Institute.